Good afternoon, everyone, and good morning, depending on where you are. We are very happy to have you in this session, and as usual, start off with some housekeeping notes. And my name is Wim van Brakel. I'm a co-moderator of this session, and I'm also a medical director at NLR and chair of the DMDI cross-cutting group. Let's have the first slide of the housekeeping notes. Most of you will be well familiar with that by now. You will have entered this workshop with your video and audio off, and if you're advised to keep that off while the presentations are going on, but during the discussion you're welcome to switch your audio back on and ask a question. Otherwise, questions can be asked through the chat function. You're also advised that the session is being recorded, so if you stay in the meeting, we will assume that you are happy with that. The preferred route to use chat is through the integrated NNN Conference platform, where you can type in your question or your comments in the chat function. It is preferred to use that since those chats are preserved also after the meeting. It is possible if you're using just one computer screen to snap both the screens, the conference platform with the chat function and the Zoom meeting both onto the screen as is shown in this slide. And if you experience any difficulties during the workshop, then you can contact the admin at nnnevents.com for issues with Zoom or the virtual platform. And if you experience any connectivity problems, you can always reconnect yourself, or in case they are more serious, watch the recording of the session afterwards. So that's it from me, and I am pleased to hand back to you, Maya.
Thank you very much, Wim. So yeah, my name is Maya Semrau. From me also a very warm welcome to this session, and good morning, good afternoon and good evening to you wherever you are. Perhaps Wim, do you want to get the actual slides set up, please? So this session is on enhancing the NTD Toolkit, practical approaches to addressing mental well-being and stigma. And so the aim of this session is to showcase practical tools for assessing and addressing mental well-being and stigma for persons living with NTDs. And I think mental well-being and stigma are increasingly recognised as being important or core considerations within morbidity management and disability prevention for NTDs, which is also evidenced by their integration into the new WHO roadmap. So I think whilst the importance of the integration of mental well-being and stigma into programs is increasingly recognised, how to do that is still less clear. So we're hoping to share with you today different approaches of how to do this, which vary by NTD and also by country context. And we're hoping to highlight tools and programmatic and research experiences from within this group. We were excited to see that there were several sessions in this conference around mental well-being and stigma, and also disease management, disability and prevention, or DMDI more broadly within this conference. And this session was actually put together by members of the working group on mental well-being and stigma, who are part of the DMDI group at the NNN. So if you're interested in the DMDI group, please do get in touch. Next slide, please, Wim. So I'm joined today in this session by, firstly by Dr. Ashok Agarwal from NLR India, who'll be talking about psychological first aid for NTDs intervention in India. Samita Kumar from the Carter Center in the US on chronic disease self-management for persons living with lymphatic filariasis in Haiti. Dr. Emeka Nwefu from CBM in Nigeria, who will be talking about mental health and NTD programs in Nigeria. Dr. Rajiv Nathan, who very kindly has taken over fairly last minute from Dr. Jaideepa Dalong, who was unfortunately taken unwell. They're both from the Leprosy Mission Trust in India, and he will be talking about telecounselling for leprosy care in India. Rose Goitius from Info NTD, who will be talking about the ILEP NNN revised stigma guides for use globally. And she'll be also doing a live run through of the stigma guides website. And then hopefully at the end, we'll have some time for questions and answers from the group. I'm also joined as workshop co-lead by Dr. Wim van Brakel, who you've already met from NLR International, and Dr. Bahadir Shelik Timur, who is the rapporteur for this session. So I hope very much that we have an engaging session and that you enjoy the session. And then without much further ado, I will hand over to Dr. Ashok Agarwal, who is the country director at NLR in India. Dr. Ashok, over to you. Thank you.
Thanks Maya for the introduction. Respected audience, good morning, good afternoon, good evening, wherever you are. Today I will talk about NLR India experience of developing the psychological first aid for NTDs intervention in the country. Next slide, please. I will be describing you the context, the PFA module development, its content, our plan for piloting, and then conclude. Next slide, please. To give you a feeling of the context, I start with the story of a leprosy affected couple. The couple in their 50s has 3 children who are in different phases of completing their education. The eldest will soon seek employment. The parents grew in resource-constrained families. As children, they got infected with leprosy, and because of improper treatment, have been dealing with lifelong disabilities. Over the years, they learned to deal with their suffering, and for more than 30 years have been taking care of leprosy affected. Recognizing their dedicated work, the wife was awarded by the President of India, but the couple still worries, and the father often spends sleepless nights worrying about their children, and the biggest worry being the children facing discrimination in their workplace and other spheres of life, for example, marriage. Now, as depicted in the slide, in India, we have around 60% of the global leprosy and 43% of the global LF cases, which can cause lifelong disabilities. And the 3 referenced studies, as you can see, authenticate existing high levels of stigma and discrimination. 94% of the respondents displayed negative attitude towards people affected by leprosy, and 50 to 70% of the respondents reported some degree of depression. Next slide, please. NLR India is implementing a core entity supported study called Reducing Stigma and Improving Mental Well-being and Social Participation amongst men and women affected, disabled by lymphatic filariasis and leprosy in 2 districts of India, namely Jaunpur and Bokaro. And the project has started implementation since March 2020. One of the research questions in the study is, how suitable is an NTD adjusted version of the PFA for use as peer counseling method to reduce stigma and improve mental well-being and social participation among persons with LF or leprosy-related disabilities. The original PFA for use in emergencies was published by WHO in 2011. It was then adapted for Ebola in 2014. We are now trying to adapt the same for the NTDs. Next slide, please. I will now describe the PFA-N development process followed by us. The surging COVID pandemic forced us to use the virtual media like this conference is using. And the good thing was that with zero budget, we could conduct a 3 days workshop with around 30 experts, and almost 50% of them were from outside the country. We could also have the participation of experts who are involved in the development of the original PFA by WHO. During the workshop, we defined the PFA-N framework and contents. The workshop participants then volunteered to draft and review as task force and review committee members respectively. And as of end August, the complete draft of the PFA-N is ready for final review, and we expect the print ready version to be available by end October. Next slide, please. The PFA-N talks about the purpose, which is to prevent and mitigate the mental health consequences of NTDs. We have kept the disease focus to leprosy and LF, as they are amongst the most prevalent. The PFA-N will be used by peer supporters. And who are these peer supporters? We have 8-point criteria for their selection. Being leprosy or LF affected, is about 21 years of age, has completed at least secondary school education, which is class 12, is a layperson from the community, one who knows the community well, one who is well accepted by the community, has good communication skill, and is willing to volunteer time without remuneration. Next slide, please. In the PFA-N, we have 6 chapters across 30 pages. The introductory chapter helps in understanding NTDs by providing a brief on NTDs, mental health, leprosy, LF, and COVID-19. Chapter 2 helps in understanding PFA, particularly the who, when, and where concept. This is a very important concept of PFA-N. The 3rd chapter provides guidance on how to help responsibly, respecting safety, dignity, and rights. The section on rights has gained from NLR experience in Indonesia. The chapter 4 is the longest and describes the process for providing PFA for NTDs with following the PFA action principles, which are look, listen, and link. So, I mean, this is very important. These principles are very important. They have been described very lucidly. The 5th chapter guides on caring for self and colleagues, getting ready to help, managing stress, rest and reflection. And the last chapter also has a pocket guide. Next slide, please. Now I talk about our piloting plan. We will be piloting the PFA-N in 2 districts. We will train 12 peer supporters in each of the districts, 3 LF affected and 3 leprosy affected persons from each district. Each peer supporter will counsel 4 persons selected purposefully as scoring high on experience stigma and depression, and low on social participation and mental well-being. And all these as per the very standard tools. We will cover a total sample of 96, randomly allocated in intervention and control arms with equal numbers of lymphatic filariasis and leprosy cases with disabilities. We'll assess the stigma and mental well-being before and after 3 months of counseling. Next slide, please. So herewith, I conclude with 3 points that based on the pilot findings of using the PFA-N, We will widely discuss and disseminate the findings of using the PFA-N in addressing the mental health issues of leprosy and LF affected. We'll advocate with WHO for the authorization of the PFA-N module, and we will advocate with government, mental health institutes and experts for adoption of the PFA-N as a strategy for addressing mental health among leprosy and LF cases. Next slide, please. So this is our last slide, and through this, we thank the development team who has contributed and is contributing, continuing to contribute till we do the final document, and also possibly they will continue to contribute while we are testing it. Thank you. Thank you. Thank you, audience. Thank you for your kind attention.
Thank you so much, Dr. Ashok, for this really interesting presentation. So we have a few minutes now if anyone's got any questions that they would like to direct specifically to Dr. Ashok in relation to this presentation. So please feel free to either raise your hand if you prefer, or to enter a question into the chat box. And actually, I can see one there from Gail Davey saying, thanks, Ashok, for describing the PFN pilot. I'm interested to hear what the control patients will receive. Would you like to respond to that, Dr. Ashok?
Yeah. So thanks for that question. In the pilot, we will not be doing any counseling to the control group. It's only the counseling based on PFA-N will only be provided to the intervention group. However, the control group will be connected with the available services in the local health facilities.
Thank you for that, Dr. Ashok. Has anyone else got any questions they'd like to ask Dr. Ashok at this point?
There's one other question in the other chat from Laura Dean. I was wondering if you could reflect on the feasibility of integrating other NTDs within the PFA-N, thinking specifically about Buruli ulcer, for example.
Thanks for the question. Well, at this point of time and in the current plan, we will be doing the integration for leprosy and LF. But then once we have witnessed the results, and if they are helpful, I think we can go to the next step of doing integration with other entities.
Great, thank you very much for that, Dr. Ashok, and for the presentation again. So we will now move on to the next speaker, who is Samita Kumar, who is Associate Director of the Mental Health Program at the Carter Center in the US. Sami, I'll hand over to you now. Thanks.
Thanks very much, Maya, and good morning, everybody. Can you hear me okay? Just to double check.
Yes, fine.
Okay, great.
Thank you.
Yes, thanks again. I'm very happy to be here today and present another summary of the work my team and colleagues are conducting in Haiti. Some of you may have heard one of our presentations on Tuesday with Dr. Luxen Desir and Martha Desir, who are part of our team. But we would really like to talk a little bit about this work, which stems from our effort to better understand how to address the mental health dimension of NTDs. Next slide, please. So the Carter Center has been a leader in NTD eradication and elimination and disease control programs for decades. And in tandem, the center's mental health program has been focused on mental health system strengthening domestically and internationally through evidence-based policy and practice. It's a natural convergence of these priorities at the Carter Center, which has really encouraged our involvement in understanding and addressing the intersection of mental health and NTDs, and being part of networks like NNN and the DMDI working group over the past few years. As this agenda has evolved from significant research and programming contributions globally, we find ourselves looking to augment NTD eradication and elimination objectives by understanding the effect they have on disability, quality of life, psychosocial outcomes, and then testing interventions that may work to improve mental well-being. Next slide, please. As many of you know, lymphatic filariasis, or LF, is caused by a parasitic worm transmitted by mosquitoes. Today's summary is focused on our research in Leogane, Haiti, which leverages the footprint of the center's LF team to better understand the magnitude of the challenge faced by people living with LF in one of the 4 remaining LF endemic countries. Our research sample in Leogane is catered to by a facility, HSC, that is really the only facility providing comprehensive LF services in the region. Next slide, please. But the impacts of LF aren't limited to physical disfiguration or discomfort. Poor mental health and stigma are common, and just like other chronic health problems, need to be recognized and part of proper care and treatment plans. Next slide, please. What's unique about HSC, in fact, is that the mental health dimension of LF has been recognized for a long time. And since 1996, it's been addressed through peer support groups called Hope Clubs. Next slide, please. Our impetus here, therefore, is to understand what interventions could address mental health for people living with LF. Following the rationale of managing LF like other chronic diseases, we test whether a chronic disease self-management tool, or CDSM, when administered in Hope Club settings, could improve mental health outcomes. Next slide, please. So about the tool. CDSM has been developed at Stanford and validated for a number of chronic disease conditions across diverse contexts, including low-resource countries. It's designed to be delivered by peers or non-health professionals and help people develop skills to manage their chronic health needs. CDSM covers topics like making action plans, the mind-body connection, problem solving, dealing with difficult emotions like depression and anger, how to manage medication usage, how to inform treatment decisions, and how to work closely with the healthcare provider. In Haiti, we've been using the CDSM tool adapted in French and Creole to train animatrices, or the Hope Club peer support leaders. Next slide, please. On the study design, we have leveraged a stepped wedge cluster randomized trial design to evaluate the effectiveness of the CDSM tool. We collect data at baseline, at midpoint, which is after the intervention has been provided to arm 1, and then again at endpoint, which is after the intervention has been provided to the control arm. And this is so that ultimately everyone in the study can hopefully benefit from the intervention and from enhanced mental well-being. We use multiple instruments and approaches, both quantitative and qualitative in this study, and the tools used are as follows. We have the Dermatology Life Quality Index, the multi-dimensional scale of perceived social support, self-efficacy for managing chronic disease, the 6-item scale, self-rated health tool, and the Zen-Milasante Depression Symptom Inventory. We have also planned for focus group discussions to better understand some other questions in our research study on barriers to attending the Hope Club and experiences undergoing the CDSM intervention. Next slide, please. Animatrices were trained over 3 weeks on the intervention by 2 local Haitian master trainers and nurses. And these nurses had conducted their training with the Stanford Self-Management Resource Institute in California. This is a photo of the animatrice training that took place adhering to COVID-19 guidance and restrictions. Next slide, please. Right now, the team is assessing midpoint data. We also plan to, right before that, the 6-session intervention was administered biweekly over 3 months. Currently, the intervention has started for the control arm. Next slide, please. As mentioned, we're assessing midpoint data, and we also plan to complete focus group discussions as part of our research study. We did want to share a little bit about baseline findings. There were no key differences between groups across baseline with the domains that were evaluated. Next slide, please. But notably, and what's worth sharing, is that there's a high prevalence of symptoms of depressive illness, 50% of the respondents that we had surveyed. And this really underscores for us the importance of having an intervention that can support people living with chronic diseases in low resource and often insecure contexts. This data was collected prior to the emergence of the pandemic, but there's also been a lot of insecurity in Haiti that has contributed to likely the symptoms and the experiences that we've seen people undergo through the chronic disease intervention period. Next slide, please. Last but not least, the study included a WHO MHGAP training for nurses and healthcare workers in Leogane. For us, this was incredibly important. Not only is it a safeguard for the participants of the study, but it's also a way of adding mental health professionals to the country's human resources and healthcare workforce. These are pictures taken from the MHGAP training. Next slide, please. So with that, a great thank you to our donors and partners, and in particular our colleagues in Haiti. You may have heard again about this invaluable work from Dr. Desir and Mother Desir on Tuesday, but this has been a commitment for us, especially during a situation that has been fluid and dynamic, and we're very happy to be continuing with it and to keep it moving forward. And we hope to be able to share more findings and data from midpoint and endpoint in the near future. Thank you. I'm happy to take any questions.
Great, thank you so much for that, Sami. That was really interesting. So as Sami said, we do have some time for questions. If you do have any questions for Sami, please do enter them either in the chat or feel free to raise your hand if you prefer. So I can see one question here from Adele Hatch. She says, what strategies did your research program implement to continue to operate in a context of insecurity in Haiti and COVID-19?
Great, thanks, Adele. I think a couple of things. One, in terms of our day-to-day project management, as I said, our colleagues in Haiti have been vital to this program continuing. They really understand when and how the program needs to be adapted to suit the needs of what's going on the ground and to really be able to reach the people that we're trying to reach. Two is that we have been very adamant across all our programs to follow the guidance and restrictions set forth by governments and ministries of health on COVID-19. So in Haiti, that meant downsizing the amount of people who were able to attend hope groups, having smaller hope groups meet more frequently, or spacing them out to accommodate the physical distancing requirements, and then working, day by day to make sure that we can continue our project activities, but still keep in mind the delays that have to be made. It is also we're also very grateful that our donors have been supportive of what's been going on the ground in Haiti, because it hasn't been a seamless implementation from design to project completion. There have been delays that have been circumstantial and out of our control. And so having a broader team that really understands that and can cater to those changes has been crucial.
Thank you, Sami. We do have some more time for any more questions, if anyone else has any more questions for Sami. Then have I missed anywhere in the chat function? Can't see any more at the moment.
No, I don't think so. I was just wondering if it is possible, it might be interesting somewhere, perhaps even on Info NTD, or if you have a website of your own, if it's possible to share the actual tools that you're using, the various questionnaires. They sound interesting, and I'm also always interested to compare between projects what they're using, and then maybe at some point we could discuss why and sort of the various experiences with these tools.
That sounds like a great suggestion. Thanks, Vim.
Yeah, thanks, Wim. That is a good suggestion. I think we have had one more question come in from Shireen Shadouri saying, really interesting presentation and great to hear about hope groups. Other than adaptations in language to the CDSM, were there any specific cultural adaptations for Haiti?
Well, we had, other than languages to CDSM, we had most of the work was completed and implemented by people from Haiti. And so I think with the adapted languages and the tools that were already contextualized, like the depression symptom inventory, most of it catered to the Haiti context already. Even MHGAP, there was already trained professionals in Haiti who were able to deliver that intervention. So there was less to do on our part to make sure that there were cultural adaptations available for use in this context. But that is something that we try to look out for from the very beginning to make sure that what we are asking and understanding is resonates with people who are hearing those questions. In our focus group discussions, for example, we've been working with specialists who have experience working with groups and conducting focus groups discussions in Haiti so that the terminology used about depression and stigma in those focus group discussions is correct and makes sense. So that's just another example.
Thank you very much, Sammy. And I think we have time for one more question. One question is coming from Kirsty Smith saying, were there particularly adaptations for particularly marginalized groups identified within the study? For example, people with disabilities, older women, etc. CBM Global is working with intersectionalities, and we're interested in how NTDs cross over not only with mental health, but with other inequalities.
So overall, I would say not overtly. I think the population we were working with was predominantly women and predominantly older women, but we are hoping to better understand some of the participant backgrounds through the focus group discussions and see if there are other identities or groups that may have factored into attendance or not attending the Hope Clubs. And hopefully we'll figure out this information in the near future.
Great, thank you again, Samia. Thank you everyone for the great questions. I think we need to move on to the next speaker now, who is Dr. Emeka Nwefu, who is a mental health advisor at CBM in Nigeria. Emeka, over to you. Thank you.
Thank you, Maya. Good afternoon, good morning, everyone, wherever you are. I am Emeka Nwefu. I'm speaking on behalf of my colleagues in CBM and HANS. I'm the mental health advisor and I'm resident in Nigeria. Next slide, please. Next. Yeah, CBM is a disability organization. We focus mainly in NTD and mental health amongst other areas. And we partner with HANS. HANS is an implementing partner working in 3 states in the north, including FCT, the Federal Capital Territory. And they've been working in this area for close to 20 years. They've been working mainly in drug distribution for the onchocerciasis, filariasis, trachoma, and other NTDs. But we've been really thinking of the best way to integrate other disorders into NTD. There's not been much attempt at doing this, but this program really provided us with the opportunity to do so. And this program is implemented in Jigawa State. Jigawa State is in the northwestern Nigeria. Next slide, please. Next, please. Yeah, that's the map of Jigawa State. It is one of the 6 states in the north central Nigeria. And Birnin Kudu is one of the local government areas. Local government area is just like a district in other areas. It's an agrarian community in the northern part of Jigawa State, with a population of just a little over 400,000 people, with very high growth rate of about 9.3%, and more of children. Population is more of youth and children, and a very high poverty in the population. Over 50% live below poverty line. Next slide, please. Next slide, please. Yeah, this program, the Comprehensive Inclusive NTD program, leverages on the structure of hands in the northwestern state of Jigawa. And the main aim of this program is to strengthen the health system and address NTD and other cross-cutting issues. It's majorly to have a holistic care, holistic approach to NTD in the local government area. Next slide, please. Next, please. Yeah, we are integrating into, we're looking at lots of relevant areas. It's quite relevant to SDGs. And the relevant areas, the goals and the target areas, we're targeting the poverty of SDG 1, and the hunger of SDG 2, and the health goals, health-related goals, and the NTD of 3.3 targets, promoting mental health and well-being, and access to medicine within the medical goals, goal number 3, and the clean water and sanitation of goal number 6. These are the goals that we aim at addressing in this program. Next, please. Next slide, please. Yeah.
There's a slight delay between me pressing the button and you seeing it, so.
All right, sorry. Yeah, in this program, we realized that the major problem is capacity gap within the primary healthcare centers. The people working in primary health centers have very little capacity for mental health. And the professionals for mental, that have good capacity for mental health and other related areas, the eye health, are more in the capital cities. But we are lucky to have one psychiatrist in that local government area. That's one of the reasons for the selection of that local government area, and also 2 psychiatric nurses. So these people provided training on image gap for the primary healthcare worker. This slide we're seeing is the training of trainers of the psychiatrists and the 2 psychiatric nurses that helped in training the other healthcare workers. They also were trained on referrals, accepting referrals and support supervision. They had to support the healthcare provider, the primary healthcare workers at the clinics, at the primary healthcare centers. Yeah, next slide, please. Now, most of the work was actually done in the communities and the primary healthcare center. After the training of the trainers, that's the mental health professionals, the psychiatrists and the psychiatric nurses, they stepped down the training under the watch of the master trainer, and they were trained mainly on identification, treatment of the common conditions and referral of these of persons with depression and mainly anxiety disorders to the secondary and tertiary healthcare centers where the mental health professionals reside. They were also trained not just in mental health, but also in eye health identification and identification of NTDs, and referring same to, and also receiving referrals to from the healthcare professionals in the secondary and tertiary healthcare centers. and then working with community structures. They are to train the community structure, the CDDs, the community-directed drug distributors within the community, the family volunteers, the caregivers within the community, and persons with disability. These are also to help in identifying persons with mental health conditions, just very common mental health conditions, and eye health conditions that are common, and NTDs. Also in providing education, they are trained to provide mental health, eye health, and DMDI education. Also working, they form self-help groups within the community to help in socializing within themselves and anti-stigma interventions. Yeah, next please. Hello, next slide please. Apart from the health component, we also have the livelihood and the WASH component. The WASH component drilled, the project drilled boreholes within those affected communities to provide water. Water is a major problem in the northwestern part of the country, is dry. And this water is to reduce the waterborne diseases and also help in irrigation farming. You can see the pictures taken from the communities where these boreholes have been drilled, and the non-functional boreholes within the community, as you can see lower down, were also fixed. They were repaired, and there were also water committees within the community were trained to maintain these water pumps and ensure that they function all the time. The self-help group members were also trained on livelihood and farming skills that they prefer, just improving their skills on these animal husbandry, and they were also provided with farming tools and trained on trade and processing and farm processing the output of their farms. They were also supported to save within the community, within their groups and within the community, to ensure that they improve their finances. Yeah, CBM is a disability organization, so we ensure that all the documents, all our materials are inclusive. We also produce inclusive IEC materials to ensure that persons with disability are included in all the work within the community. Yeah. Next, please. Next slide, please. Yeah, these are the expected outcome that by the end of this program, there will be baseline information on NTD and mental health conditions in this local government area that we are working in, and the healthcare system is strengthened to provide holistic care for persons with NTD in this pilot location. Also, the healthcare system is also equipped and strengthened to be able to identify, treat, and refer persons with NTD and other related problems within the community. We also expect that this partner at hands and the community members have improved skills to implement integrated programs in a holistic manner at the end of the one-year program. Yeah, next slide, please. Yeah, finally, there is a new program, the Mind Skin Link, is a mental health and skin NTD research program that is currently being piloted in Benue State. Is actually expected to, it's a pilot program for the WHO guide on mental health and NTD integration. It's being piloted in Benue State with TLM Nigeria and University of Jos in collaboration with CBM. It's expected to improve mental health and tackle stigma in the pilot area. It's also this program is funded through this financial support is provided by Contd and is funded by the UK aid from the British government. Thank you. Next, please. Next slide, please. Thank you very much. I'm happy to take questions and comments from.
Thank you so much, Dr. Emeka, for that really interesting presentation. So yeah, we do have a few minutes if anyone has any questions for Dr. Emeka. Please do, again, as usual, enter them into the chat or do also feel free to raise your hand if you prefer. So I'll just wait a minute to see if any questions come in.
Julian raised a hand, Maya.
Oh, okay, sorry, I didn't see that. Julian, please go ahead.
I hope you can hear me.
Yes, can hear you fine,
Yes.
thanks.
Thank you very much, Emeka. It's great to see all this work that's happening in Nigeria, which as usual is such an engine of these new ideas being taken forwards. I just wanted to mention a little bit about the manual that Emeka tantalizingly talked about at the end, and many people in this group at NNN and DMDI will have been closely watching the fact that the WHO has taken this greater interest in mental health recently, and that's really being almost finished now, that manual. And this program that CBM Global is running with TLM Nigeria is really a field testing of that manual. So we are in the very final stages of its production. I think the manual will be out in a matter of a month or so. And so people can learn more, I'm sure, through this DMDI group and the mental well-being group about that, because it really does present an exciting step forward for mental health and something people have been crying out for a long time within the NTD community.
Thank you very much for that, Julian. And yeah, I agree. It's really exciting to see that move forward and great that it's so close to being finalized now. So yeah, thank you for that comment. We have probably time for, I think, one more question or so. If anyone has any other questions or comments for Emeka. Otherwise, we can move on. I'll just wait a few more seconds to see if any questions come through. Or Vim, have I missed anything in the chat function?
No, not that I've noticed.
Okay, well, we do have some time at the end as well for further questions. So I think we'll move on to the next speaker in that case. So I'd like to introduce Dr. Rajiv Nathan, who very kindly, as I said earlier, has taken over from and stepped in for Dr. Joydeepa Dalong, who both from the Leprosy Mission Trust in India. Dr. Rajiv is a medical superintendent at the Leprosy Mission Trust in India. So thank you very much, Dr. Rajiv, and over to you. Thank you. I think you're on mute. There we go, thanks.
Thank you so much. Greetings from the Leprosy Mission Trust India. Before the presentation about the telecounseling at Leprosy Mission, I would like to share a video about the whole thing. It's a video which shows the reality about India. Given the background of rural India where we serve, mental health is not talked about or discussed. And it does not feature in conversations. And chances are if you ask them directly, they will deny it. But if the same is asked in the form of symptoms, we get some inkling of what the patient is going through. So this video is to show how the journey happened from an idea to care. We did not approach our patients with mental health questions, but rather we approached them with a general conversation about their health and subtly asked them about their mental health. This is the video that I'll be sharing, and
I think, can anyone else hear the sound?
No, I can't. I think he has maybe forgotten to put stream the computer sound. So need to unshare and then first tick that streaming computer sound and then share again.
Dr. Rajiv, when you share your screen, there should be
Yes.
2 buttons at the bottom that you can
Yes.
optimize the sound. And if you click those, the sound should come through.
India declared a lockdown due to the COVID pandemic on 24th March, and all of a sudden everything closed down, institution closed down, transportation closed down, even most of the healthcare facilities were shut down. So we had suddenly a situation where people didn't know what to do, where to go. Then we realized that most of our patients who would come to us for the leprosy care, and other care, couldn't come to us. And we knew that if they don't come to us, some could develop disability and discontinuation of the drugs and other complications. So that's where we took plan as hospitals all over the organizations, how we could reach out to our patients. And we thought of starting the teleconsultation, trying to reach out to patients as far as we could, calling them up and getting to know about their conditions, about their treatment status, and whether they develop any complication, trying to advise them how they can take care of themselves, also where the medicines could be available from the nearest centers.
We were very worried how they would cope up with the lockdown and not being able to reach out to people, and what would be their mental status be.
कोविड के वजह से गाड़ियाँ नहीं चल रहे हैं, पेशेंट हॉस्पिटल तक नहीं आ पा रहे हैं दवाई लेने के लिए, काफ़ी लोगों का एमडी तक रुका हुआ है। तो हम ऐसा क्यों ना करें, हम उन लोगों को कॉल करके बुलाएं।
मैम पेशेंट्स वो भी हैं जो लोग रिएक्शन में हैं, T1R T2R में, वो लोग स्टेरॉइड्स पर होते हैं, तो अगर उनका मेडिसिन इंटरप्ट होता है तो उनको प्रॉब्लम बढ़ जाती है।
बिल्कुल।
तो उनका भी मेडिसिन हमें प्रोवाइड करना ज़रूरी है, इधर ऑन कॉल काउंसलिंग करके या हमें किसी और तरीके से उनको कॉल करके पूछा जाए वो आने के लिए कितना पॉसिबिलिटीज उनके पास हैं।
डायबिटिक और हाइपरटेंशन पेशेंट को भी बुलाना ज़रूरी है, क्योंकि अगर उनका दवाई मिस हो गया तो प्रॉब्लम हो सकता है।
काफ़ी पेशेंट स्ट्रेस में भी होगा और साथ साथ जो उसको MCR की ज़रूरत है, क्योंकि अभी KT में काम करते हुए
लंबे टाइम से यूज नहीं कर रहे हैं, ख़राब हो गया होगा, तो उसको हमें दोबारा से प्रोवाइड कराना चाहिए।
ठीक है, हम इन लोगों को कॉल करेंगे। मनोज, जुनाइद को कॉल करना, उसका नंबर है,
आप नंबर बोल दीजिए,
9717 065 209।
ठीक।
हेलो
हेलो, डॉक्टर साहब बोल रहे हैं पूरे इसी में से?
जुनैद बात कर रहे हो? हाँ, मैं डायलिसिस मिशन से बात कर रहा हूँ, दिल्ली वाले से। हाँ, कैसे हो? वो तुम 2 मंथ पहले दवाई लेके गए थे लेकिन आ नहीं पाए थे अभी तुम, तो उसके बारे में तुमसे बात करनी थी। हाँ हाँ हाँ, तो तुम्हारी तबीयत कैसी है अभी? जो तुम्हारे दाने वगैरह हो रहे थे बॉडी पर, वो सब ठीक है अभी? उसी के लिए पूछा था, दवाइयाँ लगातार खानी है उसकी तुम्हें?
नमस्कार, ठीक ठाक है जी।
इसीलिए तो बाहर कहीं निकलना जाना मुश्किल हो
रहा है। तो अब आप ये मुझे बताओ, जैसे कि हमने हॉस्पिटल से आपको फ़ोन किया था मार्च के महीने में, अप्रैल के महीने में, तो आपको जब हमने फ़ोन किया तो कैसा लगा आपको?
जब बहुत अच्छा लगा। हाँ,
तो जो अस्पताल से फ़ोन आया तो उन्होंने आपसे क्या क्या पूछा?
तो बोले नीलम कैसी हो, नीलम कैसी हो? तो मैंने बताया मैं ठीक हूँ सर, थोड़ा प्रॉब्लम हो गई है। तो
बोले कि ठीक है, तो अभी तो मैं आ नहीं सकती हूँ। तो प्रशांत सर की नहीं, आज जैसे मैं ट्रेन चलने लगती है वैसे मैं तेरे को फिर से बोला फिर आ जाना। तो फिर दोबारा फिर से प्रशांत सर फ़ोन किए, तो एकदम 2 लोग जेंट्स वाले में एडमिट हुए, तो उसमें तो बुलाए, तो फिर मैं आई, बहुत कठिन से आई।
बहुत
एक तो ये सब बीमारी से परेशान है, और दूसरे में ये कोरोना हो जाए तो इधर मत जाओ उधर मत जाओ, सबके चक्कर में बहुत ज़्यादा डर है।
बीमारी का इलाज हो रहा है वहाँ पर?
नहीं।
क्या बोलते हैं वहाँ?
बोलते हैं जहाँ पे इलाज कराई हो वहाँ पर जाकर वहीं पे कराओ, यहाँ हम लोग नहीं लेंगे, एडमिट ऐसे।
So this was initially planned that we would call everyone and try to find out who are the people who are more vulnerable, and we would be trying to talk to them and give them continuous counseling. Inquired about their disease status. We asked them whether they had enough medicines during the period. We tried to dispel any myths that they had because of their cultural and community perceptions. We also tried to talk to them about any other minor illnesses that they had, and if they had, then they need not come to the hospital but could call us and we would guide them through the phone. Moreover, we were very worried how they would cope up with the lockdown and not being able to reach out to people, and what would be their mental status be. We also told them about what are the precautions that they had to take, about hand washing with soap and water, with how to make homemade masks, and about social distancing. What are the benefits of social distancing and how to maintain that. And they were very happy and they were much relieved after listening to us, because there were a lot of myths that were floating around, and talking to us had given them a lot of relief from the anxiety that they had. So, next slide, please. So, at this time, we at the hospital were worried about what is the patient going to do. And they were worried because they couldn't come to the hospital, and they were thinking there might be, the hospital might have been turned into a COVID hospital. There were chances of them traveling and they getting stuck in quarantine somewhere. There was a lot of financial implications. The situation was very grave. People did not have money, and transportation was one big problem. So they had a lot of anxiety and fear. Next slide, please. So our fears were that once they defaulted, they would have complications, and then complications would lead to disability and more mental stress. And then this mental stress will initiate helplessness and hopelessness. And we were very concerned about our patients not being able to travel and not being able to talk to us. Next slide, please. So we looked at what is the plus point during this time. And we realized that the number of mobile phones and the number of people having connections on the phone has increased tremendously over the past few years. And that we could tap in and we could use that to help us reach out to them and guide them. Next slide, please. And in March 2020, the Ministry of Health and Family Welfare, Government of India, published its telemedicine practical guidelines. And this article was shared with people, and we adopted some of these practices so that we can use them for our patients, so that we can contact them and get them to talk to us, and we can allay some fears. And also at that same time, we can give them some counseling and some kind of mental solace during this period. Next slide, please. So we formed a team. The team basically consisted of physiotherapists, doctors, nurses, counselor, and we all sat together and we formulated how we would start the counseling process and how we would try to contact each one of them. Next slide, please. So first, we decided whom we would contact first. And these were our patients on MDT, patients with reactions and neuritis on steroids, patient who had scored poor on the WHO 5 index earlier, high-risk patients who were at the risk of developing disabilities and reactions, those with complicated non-healing ulcers, and those with comorbid conditions like diabetes, mellitus, and hypertension. Next slide, please. So we sat together, we formed a team, and we made the listing according to the vulnerable group. We scanned all our records from our hospital management system, and we sat down and we formulated that how we would talk. We would be a very informal talk. We will start off talking about things that they would like to hear about their health, about their condition, their disease process. And during that, we would ask certain questions like, are you feeling well? Are you eating well? Is your sleep pattern the same? And then we ask them about their COVID preparedness and what do they know about the present situation? How are they dealing with lockdown? Do they understand about social distancing? And then during the process, certain myths were dispelled. We asked them if they would like us to call back, and we gave them an open invitation to call us at any time, at any given moment, and we provided them phone numbers so that they could call us back. Next slide, please. So the content of conversation was that after the introduction, general formalities, we took permission to speak about their illness. Once they recognized us and they knew that we are speaking from the hospital and they are under our care, we asked about their disease condition and the medication, whether they had adequate medication, whether they needed something else, whether the condition has worsened, whether the condition has improved, any complications that they had developed over the time, anything that they wanted to tell us about the disease, and how are they coping with COVID, with the lockdown, with the fear of being quarantined, not being able to travel to us, and are there any things that they've heard about the disease and the condition right now? And during the process, we could separate the myths and the facts. We also took this opportunity to address their worry. Because we asked them questions which would easier for them to understand. Do they have any recurring thoughts? Do they feel have bad dreams? What do they think about their livelihood right now? Are they worried about some things? Do they have palpitations? Things like that, not directly asking them about their worries, but more about how physically they could connect, and were there any signs, were they eating well, any emotional outbursts, anger. We asked about their family members, and we asked if they would like us to call back or whether they would like to call us. And this is the process that we followed while addressing each individual. Next slide, please. So this is the demographic data of the patients that we had. 138 patients were called. The maximum distance was 700 kilometers from the hospitals. 39% were from different states. 30% were females, and the average age range between 37 to 42. 115 were called multiple times with queries on medications and health. And out of 138, 37 had mental health issues like panic, anxiety, and depression. Next slide, please. This is how the data was for the patient disease. 129 were MB patients, 31 were BI positive, 82% were on NTD, 46% were on steroids for reactions, and 12% on steroids for neuritis. 13% of their patients had ulcers, and 11.4 had concomitant comorbidities. most of the patients expressed worry over the situation. They were worried about how they would cope up, how they would continue to get medicines, moreover, how would they continue to work or earn their livings. 31% said they were depressed and 65% of them called back. Next slide, please. These are the GIS coordinates of the area that we covered. Next slide. Yeah. So we had a lot of learning from that, and we realized that the mental health communication is more to do with person to person and not expert to victim. There has to be a lot of relationship and trust building. We cannot be judgmental, and we have to listen to them, and through the answers that they gave to our questions, understand the unseen. As compared to the face-to-face versus phone call, we were at a loss because we could not see the person and the body language was not known. We were not trained as counselors or as clinicians to understand the nuances of the voice change, whether what they were saying is appropriate or exactly what they were feeling. But at least when they were not face-to-face to us, it was less comforting. Some of them were less confronting, and some of them were open to talking to us, where they would not have talked about certain issues when they were facing or sitting next to us. Next slide, please. The challenge was it was a pilot activity and we were not fully prepared. We did not have there were lots of gaps in our knowledge. As I said, that we were not trained to understand the nuances of the voice. We were not trained to ask appropriate questions and to deal with a situation like this. Females did not have privacy. Usually households share one phone between them, and it was difficult to ask them pointed questions about their mental health. It took time. It took a lot of time to build the trust. Multiple calls were shared about over the period of time, and because of the unfamiliar counselors, but finally it reaped benefit. Lots of bridges could be built, and lots of myths could be broken. Lots of people were comforted, and they would understand. And between the right and the wrong information, the information could be channelized and given to them and presented to them. Gender privacy had to be maintained, and network was a challenge in some cases because some of them were in remote areas, and when you call them, they could hardly talk. So there were multiple times that we had to contact them. Next slide, please. So future is maybe during this time of the pandemic, this is the way forward for many of us. We would need to have modules. We'll have to formulate them, and then we need to have a capacity building exercise for us to understand and to be able to deliver this in a more comprehensive way, in a better way. And there's a lot of research options, which I think the panel here and the people listening would be able to give us. And I think that it would be a very fruitful venture if we go ahead and we just could develop it in a finer way and in a better way. Next slide, please. And I thank all the generous sponsors. I thank the Leprosy Mission Trust, India, the hospital, and especially the patients affected by leprosy who responded in a very positive way and made this process a thing that we cherish, and we feel that at least there was a time that we made some change, some impact on the way they think and the way they would perceive the pandemic and the COVID and the mental health issues that they have. Thank you.
Thank you very much for that, Dr. Rajiv, for that interesting talk and also for putting together that video as well. So I think we have just time for one question. So let's see whether, I think there's one question come up from David Bainbridge. It says, thank you, Dr. Rajiv, for the clear presentation and sharing your learning. Do you have a sense of the number of patients who could not be reached as they were without a phone proportionate to those who could be reached. Any alternative strategies for these situations, given the heightened vulnerabilities?
20% of the people had given numbers which, when we called, could not be connected. There were some who were connected and we were not able to talk to them. We deal with migrant population. We deal with people who are here and so some days and then they move and sometimes their phones are not. And during the pandemic, some of them may not have had the money to even recharge their phones. So we lost out on that. But considering the number of people we could reach and the way that we could talk to them and could really discuss things with them, I feel that it is an opportunity that we really dealt well with. And people who would not been reached, I think we should ask for 2 or 3 numbers if they can share with us, because in this time there is no other way of communication when people are locked down and there is difficulty in transportation.
Thank you very much, Dr. Rajiv. So we need to move on to the next presenter now, who is Rose Goitches from NTD, where she's the Coordinator and Information Officer. Over to you, Rose. Thank you.
Thank you, Maya. Hi, everyone. My name is Rose Goitches, and I will be showing you a live demo of the stigma guides today on behalf of all the authors. Stigma is a major barrier to achieving universal health coverage. And as you all know, many of the 20 diseases classified by the WHO as NTD have stigmatizing consequences. Mental well-being and stigma are increasingly core considerations in NTD programs. And collaboration between the NTD and mental health sector are increasing. And it is therefore important that health and social welfare departments, NGOs, and people affected agencies have a good understanding of what stigma is and what can be done to reduce its impact. From 2018 to 2020, a temporary expert group has rewritten the stigma guides, which have been developed and supported by partners from the NTD sector. Next slide, please. Originally written with a focus on reducing stigma in persons affected by leprosy in 2011, they were updated during 2018 and 2019 by professionals active in the NTD sector and persons affected by different NTDs to incorporate improved insights, align with current evidence, and to make mental well-being an integral component of the series. In the second quarter of 2020, the ILAP and NNN guides on stigma and mental well-being have been launched on Info NTD. And the guides provide best practice information and recommendations from various disciplines on how stigma manifests, how it can be reduced, and the tools available to assess experienced stigma and mental well-being. So although written with the focus on NTDs, the content is relevant to address all forms of health-related stigma and promote mental well-being in interventions, policies, care packages, trainings, and other services. All 4 guides have useful tips for further reading and links to tools that could prove useful to those working in NTD-related activities. Next slide, please. When the guides were rewritten, we discussed the requirements for sharing the guides with the NTD community. So the guides should be easy to navigate through, the content should be easy to translate, should be easy to search through the content, but also editing, so the guides can become more of a living document. It should be easy to access the guides via a mobile phone, and we should be able to monitor the usage of the guides. Considering the requirements, it was quickly decided that the guides should be made available online, keeping in mind the target audience is globally spread and that the guides should be accessible for all. Info NTD is an online portal that shares information on cross-cutting issues in NTDs, such as stigma, mental well-being, and disability inclusion. In 2019, the portal was renewed, and the web pages of the portal are developed in a way that they are easy to access from all over the world, and search results are not heavy to load. Many of the research tools that are discussed in the stigma guides, such as tools to measure experienced stigma, for example, they were already available on InfoNTD, so it therefore made sense to launch the guides via InfoNTD. The guides are also available via InfoLab, and InfoLab is an online portal that shares information on leprosy. And InfoNTD and InfoLab share the same database at the back end, which enables making content available on both portals by uploading it only once. Well, enough said about the guides. Let's have a look online. I'm going to share my screen now. I hope you were able to see my screen?
Yes, we can see it, thanks.
Okay, great. This is the homepage of InfoNTD, and the guides are available via the Toolkit menu. So here on top you will find Toolkits, and here on the left side you will find the guides on stigma and mental well-being. To make things more easy, also communications-wise, we created a URL for the guides that redirects to the same page. So the URL is stigmaguides.org. It's already appearing. And when you use that URL, you will go to the same page, the main page of the guides on stigma and mental well-being. So if you scroll down a little bit, you will find an introduction, more information on the publication details, the contact details, and also the supporting partners. We just spoke about the requirements of the guides, and one of the requirements was easy navigation. And at the bottom of each page, you will find a previous and a next button, which enables reading the guides like a book. It's also possible to navigate here by using the menu on the left. And as you now see, I have moved from the home page of the guides to the main page of Guide 1. The stigma guides consist of 4 guides. Guide 1, what are health-related stigma and mental well-being? And it's now open, so you will see all the chapters here below. Guide 2, how to reduce the impact of stigma. Guide 3, how to reduce sources of stigma. And Guide 4, how to assess health-related stigma and mental well-being. Now let's walk through the guides together and explain a little bit more on the training exercises. So all 4 guides share basic learning goals, and they provide exercise sheets and tips for use in education and training. The guides, they are not a training course or program, but the content is rather practical, and we would like to encourage the guides being used in interventions, in training and care packages by using a learner-centered approach instead of lectures. And learning, especially on a topic like changing attitudes on stigma, it does not happen by lectures, but demands really a more personal learning process. So most exercises therefore stimulate active participation and relating the material to the participants' own context. I'm now opening Guide 2, Chapter 2. So throughout the guides, you will find web links provided in dialog boxes. And I will scroll down a little bit through the content so you can have a look. And then here you will find such a dialog box showing exercise 2, practice exercise. So by clicking on this link, Guide 2 Annex 1, it automatically redirects me to the annexes, which they also can be found here on the menu in the left. And here on top, you will find Guide 2 Annex 1 training exercises and tips. And the exercises are very practical. You can use the exercises which suit you, adjust them to your situation, or let them inspire you. And I'll give you one example of exercise 2. That is, participants come up with interventions to reduce the impact of stigma by putting themselves in the place of a stigmatized person. The objective of this exercise is to get into the topic and activate participants to think about it. So very, very practical exercises. So now let's have a look at the content of the guides. And I'm now going to guide 3, chapter 5, interventions by source type. So besides exercises, you will find the dialogue boxes that show testimonies, case studies, practical tips, and also links to further reading and examples. So here you'll find information on community awareness with tips on raising community awareness, further reading. And here you can see a box that shows examples of stigma in health services. And when I scroll down a little bit further, you will also find key strategies to reduce stigma in healthcare settings. The other requirements for putting the guides online were that content should be easy to translate and that it should be possible to monitor how the guides are used. So on the top right side of the page here, you will find a select language button that enables translating content to over 80 different languages by using Google Translate. And we all know that Google Translate, how it works. It will probably not translate 100% of the content accurately, but at least people who do not speak English have access to the guides as well. I'm now choosing Afrikaans as a language, and as you can see, the content is being translated immediately. And let me also put it back to English. Should any of the users of the guides officially translate the guides as or part of the guides, then we would be very happy to upload these translations to Info NTD as well. So please get in touch with us if you know about any available translations. What's next? We would very much like to understand how the guides are being used, and we are planning to collect information on the professional work field of users and how they intend to use the guides, with the purpose to further update the content and to increase the usability. As mentioned before, the guides should be a living document. So for this reason, we're currently in the process of developing a pop-up window in which we will briefly ask a few questions to the visitors of the stigma guides. And additionally, the guides will also be shared in a downloadable PDF version, and I've opened guide 1 now on my computer to show you an example. And the PDF versions are almost ready to be uploaded, so that's very exciting. We welcome any questions, comments, and suggestions on the guide. And yeah, thank you for your attention. Back to you, Maya.
Thank you so much, Rose, for that really interesting insight into the stigma guides on the guides on stigma and mental well-being. Thank you. So we have some time left at the end for more questions. So please feel free to ask any questions again via the chat function or raise your hand. If there are any questions that we've missed along the way, please do feel free to re-enter them into the chat box so that they reappear. So either any questions for Rose or for any of the other speakers, please feel free to go ahead and ask those. So I'll just give a minute. Wim, are there any questions that we've missed along the way that I haven't picked up that you're aware of? That have come up in the chat function? I'm trying to see if there's any that I've missed as well, going back.
No, there's
yes, I think
a couple of compliments, but
There was one by Madel Hack saying, please describe your advocacy efforts with the local government, Ministry of Health, etc., related to mental health supports. Was this for Dr. Ashok, if I remember correctly? Or
yes, that's right. Yeah.
Is that Dr. Ashok, you could comment on that, please, or respond to that.
Yeah, sorry, I missed the question. Can you please repeat, Maya?
So, it says, please describe your advocacy efforts with the local government, Ministry of Health, etc., related to mental health supports.
Okay, so we are doing this effort in consultation and collaboration with the local government. Like we have we have advisors on our board. There is an advisory committee, and where we have from the local university, we have an expert, and we have expert from the premier Ranchi Medical College, which happens to be a referral hospital for mental health issues. We are also in touch with the Psychologist Association, who can further guide us on how to implement it once it is tested and found to be useful.
Thank you very much, Dr. Ashok. And then there was another question from, sorry, yeah.
No, so I was going to say a question from Gail Davey was the next, I think. Could each of the presenters give their views on how we could increase communication across these fantastic projects?
Anyone got any thoughts they'd like to respond on that? Any of the presenters?
Maybe I can jump in, Maya, and make a plug for joining the DMDI Mental Wellbeing and Stigma group. I mean, it would be so great to leverage this platform and continue to leverage this platform, which has already done quite a bit of work in this regard, but to share the work that's being done by many of the member groups within NNN. And we're hopeful that sessions like this will bring your attention to platforms like the Mental Wellbeing and Stigma group, but also give you points of contact to be able to share the work that you're doing, and we can, disseminate it more widely through the group as well.
Yeah, thank you very much for Sammy, and I was also gonna make that point as well. So thank you for that. Vim, did I just hear you
make one additional comment? Sure. I think that is the best answer probably, and also the most long-term answer. But just to give you a heads up for the coming core NTD meetings, there will be one core NTD breakout session, which is specifically geared at sharing between current mental health and NTD research projects. So there are, I think, 7 projects lined up that we'll be sharing very briefly, and then there will be a discussion on sort of cross-learning from those projects. So the nature of that breakout session is slightly different from the traditional one, but that is upcoming in the core NTD meeting.
Thank you, Vim. Thank you. So I think we have been told that we can go up to 10 minutes over the actual workshop session time. So for those of you who are able to stay on, we are very happy to stay on and take further the questions if there are any. We will get cut off in about 10 minutes, but we're happy to stay on for another 10 minutes for those of you who are able to stay. So Vim, was there any?
Yeah, we have one question from David Bainbridge to Rose. Any plans for to continually refresh or update the guides and maintain the site as a living document with the latest insights and learning? Rose, would you like to respond to that?
Yes, thank you, David. Well, yeah, the guides have just recently been launched, and yeah, we can make edits to the portal basically at any time. So it's also a little bit depending on the feedback that we get from the users of the guide. And Wim, if you have anything to add to this?
No, I think I mean that is indeed the answer. We hope to update, and I think it's important for a forum like this, and also, of course, for the members of this mental well-being and stigma group. If you notice anything, either that should be changed or updated, or if new insights do come out, we don't necessarily notice everything. So if you have additions you think are valuable to make, please send them to Rose or to Maya or Sami, and we can then ensure that that gets looked at carefully and added if relevant.
Yes, and yeah, in addition to that, yeah, also other tools or documents or practical information that we could share via Info NTD with the wider NTD community are also welcome, of course.
Thank you very much. So, was there another question in the chat box, Wim? I think I saw one.
Yeah, well, there was one more highlighting a question from David Bainbridge earlier that I'm interested too. This was from Shireen, Dr. Emeka. Were there any particular strategies addressing stigma that were most successful? Anything that you can say yet already about that?
Yes, there is a planned strategy, but the program is still too early. It has not been, we've not started the implementation. This so-called social contact, where persons that we call champions that have done well with mental health conditions and NTD visit social gatherings like places of worship, town hall meetings, market squares, to discuss with people, make contact with people, to debunk all the myths about mental health conditions and NTDs that they have. And this helps to bring people with these conditions with the other people within the community to see that most of those myths are not correct. They are myths, they are not really facts. So that has not, or in this project is planned, but the project had some delay, and because of the COVID, the training of the trainer just happened after the lockdown. So we are going to also pilot that during the period of the program. Yeah.
Thank you, Dr. Emeka. Any other further questions to any of the speakers, or to anyone, in fact, within this session? Or any other comments that anyone would like to make? Wim, are there any that I'm not seeing?
No, I don't think so. No.
Okay, I'll just wait another minute or so just to see if any other question comes in. We are over time already, so I am aware that people probably do need to go as well. So I can't see anything else coming in. So in that case, we will probably move to closing the session.
Yeah.
So thank you very much to all the speakers. Thank you very much to all of the attendants for a really engaging and interesting session. I very much enjoyed it and hope that you did too. I hope we'll all see each other again in the plenary in about 25 minutes time. So
thanks
glad
to Russell and Sally.
And thank you for, exactly. Thank you to the MYT team for your help with the session. Thank you very much to everyone. Goodbye.
Okay.
Thank
Bye-bye.
you.
Thank you. Thanks, Maya and Wim.
Bye.
Bye.
Thanks.
Bye-bye.
Bye.
Bye.